Hey everybody, this is Carol from the Society of Thoracic Surgeons. This is the Adult Cardiac User Group call for December 16th. We're going to get started now. We will have open phone lines again. If you'd like to speak, just use the raise hand function and we can unmute you. We'll also be taking questions through the Q&A. We'll see how it goes for this time. I'm not sure if we'll be able to get through everybody's questions because it seems that the raising hand function takes a little bit longer. So if that happens, maybe we'll limit the open microphone raise hand function to maybe once a quarter or something like that, but let's see how it goes and we'll get started here. So on the call with me, I have the usual suspects, the STS and IQVIA staff. Thanks everybody for joining. Couple STS updates, the IQVIA update, and then user feedback. Please, if you have submitted a ticket or submitted an issue to IQVIA, please include your ticket or case number. Along, if you know your PID, please include that as well. Again, you could use the raise hand function and be sure to unmute yourself, or if you'd like to submit the question using the Q&A function. We'll get to those after the presentation. A couple STS updates. We have the December training manual has posted. Oh, I forgot to remove. It has the AQO updates, but those were posted in November. Harvest 1 2020 benchmark report is being finalized at IQVIA. Harvest 3 2020 closed on September 4th. Those COVID-19 positive patients will be removed from analysis. The data has been received back from DCRI to IQVIA, and they are working on getting that uploaded for sites. Harvest 4 closed on December 9th, and the Harvest closed on December 9th. Opt-out was December 11th, and that data will be sent over. IQVIA will be pulling that snapshot soon. Harvest 2021 schedule was posted earlier this morning, so it is available online, and I can show you where to find that. We'll do that shortly before we go to Q&A after the IQVIA update. Don't let me forget. And then public reporting is expected to be updated in mid-March of 2021. And that will be using the Harvest 1 2020 data, which is OR dates through December 31st of 2019. And don't forget to claim your CE credits for AQO by December 31st. After December 31st, you will not be able to claim your credits. Starting with January 1st, we will be utilizing a temporary yes or no field to collect information on this Edwards PhysioFlex annuloplasty ring, any size. It's ELS 5300. This is coming from our research department. We need to start collecting this we need to start collecting data on this device. It was approved in March 2020, so it did not make it into the data specifications for version 4.20.2. We don't usually do this when new devices are approved after the data version, but it's a special request coming from our research department that we start collecting data on these devices. It will be added into the mitral implant section, which I have a snapshot down here, and we'll put it in underneath this UDI here. It'll just say temporary yes, no to YN2 with a yes or no. If this device was entered, you'll just check yes. We'll go over it again in the January monthly webinar at the beginning of the month. I will send out notification to vendors and sites and update the data collection form by next week. And I'm going to hand it over to Joe for his update.
All righty, thanks so much. Good afternoon, everyone. We're going to go over some items that were updated this past weekend on the 12th of December. And there is a notification posted that lists these bug fixes out for you as well in the notification section. Starting with some configuration updates, STS 4572. The validation message for prolonged post-operative pulmonary ventilation greater than 24 hours was incorrectly referencing the previous cardiac interventions variable, so that has been corrected. STS 4766, there was a validation for the urgent, emergent salvage reason variable that was appearing incorrectly, and so that issue has been resolved. STS 4573, the patient ID has been set to be a required field, and if it's missing, a critical error will fire for that. STS 3575 for direct data entry users. We did add text at the top of the case form for direct data entry users to help clarify that cases must be saved as complete in order to be included in the harvest. And you'll see that if you are a direct data entry user, you should already be seeing that text at the top of the page. So make sure that if you are intending a record to be included, that you are checking that complete box before you save. STS 4407 for fields where you can check multiple options, so the multi-select fields, these will now be displayed in columns rather than a single scroll box, which should help make those a little bit easier to read for you. Regarding the non-analyzed or the participant dashboard, STS 3057, we did have a report of a situation where the readmission reason for a readmission was being incorrectly categorized, and so that has now been corrected. And then several items on the last section here related to the missing variable report. So with that release over the weekend, we did correct several issues where variables were showing up on the report when they should not have been. So among the variables that should now be corrected are the AV aorta procedure performed, the RF liver disease child PU class, the HIC MBI number, the organization participates in adult anesthesia section, and the total post-operative ventilation hours. So all those items should now no longer appear in your missing variable report incorrectly. All right, and so that was everything in the December release. Now we have a few items that are currently under review, starting with for direct data entry users, STS 5084. The STS patient ID is displaying an incorrect auto-generated value on the case list. So for direct data entry users, when you're on the cases tab, you may see some incorrect values there, and we are looking at correcting that for you. ACSD participant dashboard 4262. We are working with the STS to improve the functionality of the participant dashboard where it concerns the readout of the operative mortality variable. And so we are making some updates on the calculations behind the scenes based on that feedback from that conversation. And so those items should be added in a future update. SCS 4450, an issue with the report logic was referencing the wrong parent field values, was causing deep sternal wound infection to display incorrectly as missing on the dashboard. So we are looking into that issue. SCS 4183, there does seem to be a lingering issue with the liver disease child PU class variable where it relates to version 2.9 records. So we are looking at cleaning that one up. And then some notes regarding the MIPS performance report. This is logged under STS 4732. So the updates that are coming are that all measures should exclude patients identified as still in the hospital. And the measured tobacco use screening and cessation intervention, so 226A and 226B, those criteria will be updated to include former smokers in the performance met criteria. All right, and as always, if you have submitted any tickets that we have not discussed on today's call, please rest assured that they are under review and our support team will follow up with you on resolution or confirmation when those issues have been resolved.
Great.
That's it for me.
Thank you, Joe. And I wanted to just give an update. This mortality one is kind of a big deal for sites, and I wanted to let all folks on this call know that STS, IQVIA, and DCR are working closely to make sure that this calculation is updated per the requirements. DCRI does some calculations in the background to get the true definition of operative mortality, which is those patients that died in hospital or those that die within 30 days of OR date if discharged from hospital, discharged alive, died after discharge within 30 days of the OR date. So there's a little bit of extra logic that goes in the background related to the dates on those, that calculation that has to look at operative mortality date, OR date, discharge date, and things like that. But not things like that, but those dates. So it's a little bit more tricky than just displaying an operative mortality field related to how the parent-child, because of the parent-child relationships. So IQVIA is displaying the true operative IQVIA is displaying the operative mortality as it's listed on the data collection form, which is that field MTOPD in the discharge mortality section. That field is excluding the inpatient deaths. So we're working closely with them, like I said, to make sure that we can provide you with another field that shows your operative mortality fields that are including the inpatient deaths. So that is coming, and STS is aware of the necessity for sites to have this number, this operative mortality, the true operative mortality displaying correctly, or displaying the true value for you. Also, we are aware of the elevated need to get that to you as soon as possible. And then the IQVIA support plan, same, reach out to ststechsupport@iqvia.com, or you could call the number 833-256-7187. Tier 1 will route you to Tier 2 or STS, and then we work with vendors or DCRI as needed. It could take 24 hours for a response, 24 hours or 1 business day for a response. When you do reach out, and if you've already have a ticket number, please include that along with your PID so they don't reopen another ticket. Then the resources, the STS National Database webpage, the STS Tech Support at IQVIA.com, or the STS National Database feedback form, which is available on the STS website. And then we can go to questions and answers, but before we do that, I wanted to go back, because we've had about 20 or so people, actually about 30 people join after I did the STS update. So I just want to go back and touch on that real quick. And if I don't get a chance to say before we hang up, happy holidays and a peaceful new year to you all. Our next call is January 6th at 2 p.m. and that will be our monthly webinar. I'm going to go back here to the beginning and just go over the STS updates one more time for those folks that join late. And I know, I don't like to waste people's time, but some of these were pretty important. The Harvest 1 benchmark is coming soon. IQVIA is finalizing the programming issues. Harvest 3 closed. The data is back from DCRI to IQVIA. They're working on uploading that. Harvest 4 data has closed and will be sent over to DCRI in the coming weeks. The Harvest 2021 schedule is posted, and I wanted to take a minute to show you where that is at. 1 second. Okay. If you go to the STS homepage, of course, it's going to take a second to load. Under registries, STS National Database, don't click on any of these green boxes, even though they look enticing. Don't click on them. Scroll down a little bit and you'll come to a list of important resources. The 5th one down will be your harvest schedule and information. And you'll see the harvest schedules have been updated for 2021. So I know folks like to plan their vacations, which just shows your dedication to the database and to your jobs, to your professions. You can now plan your vacations if you use the schedule to do so. That really speaks a lot. I share that kind of jokingly with a lot of our surgeon members and other people, how serious our data managers take their responsibilities with the data at their facility, and that a lot of them plan their vacations around our harvest schedules, especially around the holidays. The other topic I wanted to point out was for folks that join late is starting January 1st, we will be collecting data using this temporary yes or no field. It's called temp YN2. As requested by our research center, we will be collecting this Edwards PhysioFlex annuloplasty ring which is as ELS model number 5300, and any size will go in this field. I sent an email out. I want to say it was probably to, there we go. I sent an email out probably to a couple hundred, 300 or 400 sites who were using this field to collect data. And these fields, these temporary fields, are only to be used if directed by STS for an STS specific project. About 300 or 400 sites were collecting fields, data in this field outside of being directed by the STS to do so. If you have, or if you are using these fields, you need to stop using them, because we will have data going in there that's STS related on January 1st. And you will lose your data in there. So please stop using these fields if you're doing so for internal purposes, and work with your vendor to have them put in a site-specific field within your vendor software. This temporary field, I'll add it into the data collection form in the mitral section, under the mitral implant section. And it'll say, was an Edwards PhysioFlex annuloplasty ring inserted, yes or no? And you can select the correct answer. And then I will send out notification to vendors and sites, DCRI and IQVIA, by next week, and I'll have an updated data collection form posted as well. So those were the STS updates for the group, for those people that missed that or had additional questions. So let's go over to the Q&A, and if anybody would like to speak, you can feel free to raise your hand and we can unmute you. Right now there's about 11 questions in there, so I'm going to start with the Q&A and see where it takes us. The first question is, how long do you recommend we keep paper data collection forms? 2 or 3 years? And this is a great question, Rita. We do get this question quite a bit from sites that collect on paper. And my recommendation has been, because we do audits, and the audit can go back, not just the audit, but in addition to the audit, the outcomes reports go back 3 years. So for valves, it goes back for 3 years. So on a case that was done for the outcomes now, so say we're going to look at Harvest 1 2021 data, and we're looking back, that would include data from 2020, 2019, and 2018. So if you have a question about a case that happened that's included in that composite outcome for a 3 years composite, then I would suggest that you hold on to those records, paper records, for 3 years, especially if you take notes on them, so you can refer to it if you have any questions. For auditing purposes, we are going to audit in 2021. We will audit a half a year of 2019 and a half of a year of 2020. So we're going to audit July 1st through December 31st of 2019, and January 1st through June 30th of 2020. So it would be important to hold on to those records for at least all of 2019 and all of 20. So that would be 2 years worth. I would recommend the 3 years though. Next question is, a patient was in a nursing home. Their roommate was COVID-19 positive and passed away. The post-op patient was very ill, arrested, and was readmitted. Patient had a rapid antigen test and it was positive. Is this acceptable to test, is this an acceptable test to code 14, which is a yes answer? And was the patient tested COVID positive? The answer to that is no. You have to have a PCR positive test. It cannot be the antigen test. So this patient needed to have a PCR test to check for COVID positivity. Next question. I checked the IQVIA website this morning, and the risk-adjusted models for Harvest 1 national report, as well as the anesthesia module reports, are still not available. By the time we receive these reports, the data will be a year old. How can we justify the added expense of participation in the anesthesia module if the reports are so delayed that they are a little value for quality improvement? So the risk-adjusted reports for Harvest 1 are available. What's not available at this time is the benchmark report and the anesthesia report, which will be part of that benchmark report. Certainly understand that this is a very off year related to getting your data back so late. And I agree that having data that's over a year old or even a year old is not very helpful for quality improvement at sites. But we are doing the best that we can. STS, IQVIA, and DCRI are all working together to get that data posted as soon as possible. If you'd like to reach out to Donna McDonald, if your administrators have specific questions for her, we can certainly put her email in the chat box. Leanne, if you wouldn't mind doing that.
Will do.
Thank you. Next question to IQVIA. Validation with error messages to check lab values. Is the validation using as per manual users or real value? Manual user. I'm not sure I understand that question. The validations that are in place at IQVIA for the lab values are those that are provided in the data specifications. And it specifies if they're real values or integers.
I think we're using the usual lab range values. Maybe that was a sort of autocorrect from usual to user.
So the usual value should be showing up as a warning.
And those are.
Yeah, and the high and low value should be showing up as critical.
Yes,
Correct.
absolutely right.
Okay. Okay, I'm gonna go over to Linda Denning, who is her hand raised. And Linda, you're just gonna have to unmute yourself. Go ahead, Linda. Oh, we can't hear you. Okay, I'm gonna take, Linda, if you can figure out your mic, then speak up. I'm going to go to the next question, which is coming in regarding TINs. I'm sorry I missed the first couple of minutes. I was getting error message that the TIN is missing. Will this affect the harvest report? Will TIN be required in the future? So right now, TIN, the error will not impact your data going into analysis. It's just letting you know that this is a very important field and you should do your best to try to get this information into your records. TIN is required for MIPS reporting for any physician that you have that's participating in MIPS through the STS. It is not required for cases outside, for physicians outside of that. However, it is likely that CMS will offer different types of reimbursement or payment models in the future that will require TIN. So we're encouraging all sites to get those TINs in, starting with the January 1st, 2020 cases. So in the future, that is available if we need to assist with payment reimbursement for your surgeons through CMS. Linda, are you there? Okay.
Yeah, Carol, she had raised her hand accidentally, so sorry about that.
Oh, okay, got it. Thank you. Oh, hold on. Okay, next question. I was in the dashboard and noticed that some of the values represented do not have the decimal in the correct spot. Instead of a percentile being 2.0, it was being represented as 20. I do not recall which section this was, but there was multiple areas like this. Can someone review the dashboard and correct them, please? IQVIA will be happy to look into that. And if you could send us a specific example of where you saw that, Heidi, that would be really helpful. We go in there quite a bit and try to catch that type of information, and I haven't heard that, but maybe IQVIA is aware. Okay, next question. If we are excluding COVID-19 patients from analysis, are these going to be taken out of the case volume count for the participating hospital? So they will be taken out of your the needed number of cases to go into analysis. So if for cabbages, for example, the limit is 10 cabbage patients are required to be included in analysis. If you have exactly 10 patients and 2 of those patients were COVID positive, then you would not meet the requirements to be included in the analysis. We are going to, IQVIA will be providing back raw data on the COVID-19 patients in a separate type of, on the reports, but not included in the risk adjusted reports. Next question, when should we expect our CE certificates? So for AQO, if you, I believe that they are sending them once a month. So if you completed it in November, I think that you should have it. I received mine. I received mine earlier this month. I completed my certification or my certificates in November. So you should have them. If not, Leanne, could you please put Emily's email in the chat box? Yeah, if you don't have, if you feel that you should have them and you completed them in November or October and you have not received them yet, then please reach out to Emily and she can check into that for you. I'm going over to Donna, who has a question with her hand raised. Donna, if you're there, just unmute and go ahead. Are you there? Uh-oh. Okay, I'm going to go to the next question. Melanie, did you want to take the question from Kimberly?
Yeah, I actually was trying to type the response back to her, but I can say it. I can take it. I was like, I can't get back to the chat box, but Kimberly, let me, so the initial question that she had was related to on the case form. She saw that there is a complete checkbox that is available, and she wanted to know whether or not checking that option was going to impact her cases when it came to harvest. And there was, I guess, an item where we have a platform enhancement. It's for direct data entry users. For direct data entry users, they use that method to indicate that their case is finished, and that is what will be sent to analysis. But for those that are not direct data entry users, you're uploader only, you do see that checkbox, but you are not allowed to save that actual record since it's in a read-only mode. So checking that box will not actually do anything in regards to preventing it from going to analysis, because it's not going to allow you to save it. There's no option for you to save that change. So Kimberly, that's what I was saying. At the very top of the window, you will see that there's no option for you to actually save. Hopefully that clears up that question, and others may have had that same. So hopefully that cleared up that that question.
Great, thank you, Melanie. Next question is, have the yearly bills for STS and anesthesia modules have been sent out? They should have been sent out last week. If you did not receive it, Leanne, I'm going to ask, sorry to make you do work. If you could put the STSDB email address, or Jane, do you know? I think Jane's on, not to cold call on her. Maybe she stepped away, but maybe we could put the email to STSDB in the chat box for folks to reach out if, I think that's who they should go to with billing questions if they haven't received them yet.
Yep, we'll do.
And I apologize to Jane ahead of time. Teresa says, why are we collecting data on annuoplasties for companies? So we're not collecting data on annuoplasties for company. It's a device that we've been asked by our research center to collect if it's being inserted or not. Typically, this device would have been added in at the start of version 4.20, but because it was FDA approved in March, it missed the data specifications when they were sent to the vendors. So we've been asked to add it in as a temporary field. If a patient does not have a mitral procedure, should we leave the yes or no temp field? No. Yes, you'll leave the field blank, and Melinda and I will come up with some language in the training manual to make that very clear. Also, in the email I send out, I have sent out next week, will include further information, but you'll leave it blank, which means that it will show up as missing on your missing variable report, but you can ignore it for those cases that were not mitral valves, or just ignore it. It wouldn't worry about making sure you check if it's showing up on your missing variable report. Next question, what is the max CE units for the adult open heart day? And I was going to try to see if I could see that. I think it was over 20 actually, but let's double check. So it was more than what Illinois required for a 2-year relicensing, which I was very happy about. Let's see. Maybe I don't think it's on here. Oh, maybe. No, I don't see it on here. But I know that it was definitely worth it. It covered me for 2 years for my Illinois license. So why is the data submission end date 2/12/21? That's not even halfway through the month when we would normally have at least another week. That will give you the 30 days post-op, and that's when we have it because we have to have the data in. Last year we had to move it late because of the original transition over to IQVIA with DCRI. So it's actually the week that it should be is the week of the 12th. Will the new report have a place where the COVID exempt patients will be chronicled? Would be helpful for representation of the population removed from analysis in contrast to our local count. So you'll see the COVID, I'm not sure exactly what you're asking, Heidi, but the report that we have with the COVID patients will show you all of the COVID and I believe how they were coded. Do we have any more information on that, Jeanette or Melanie or Rhonda?
It'll be an update. The expectation is it'll be an update to the existing participant dashboard report. So it won't be a whole new report. And the plan is to allow both filtering the COVID positive patients out, as well as to show the response options that were selected on the forms. So you could include everything. You could filter just on the no's. You could filter on the yeses. And then you can see the responses filled out within the updated dashboard.
Great, thank you. Next question. Will Harvest One 2021 request cabbage only cases back to 3 years, which is similar to Velca cases? Oh, I think you mean valve cases. I'm not sure. I don't know that we have a date yet when that 3-year cabbage composite model is going in place. We will communicate that out to sites when we have more information on that. Next question. I am fairly new data manager abstracting adult cardiac, cath PCI, and TAVR. I am amazed that there are so many differences in definitions for essentially the same metric. EF in one is the lowest range. Another is the average. Has there ever been meetings of minds in coming up with common definitions? So yeah, actually, we met adult cardiac. Well, I manage adult cardiac for STS, and I am the STS staff manager, I guess, if you will, project manager for the STS side of the TBT registry. And we do meet to review definitions for both databases. Cath PCI should use, I believe they probably use the same definitions as the TBT registry because they pull from the same group of data elements. We do meet to review those definitions, and sometimes we can't always align on our same definition. And because we're using the EF in the risk model, the reason why we use, I think, is ours the lowest, Melinda?
No, it's the average.
We use the average, but it's a good question. And then we brought it up to the surgeons, and I can't tell you exactly why we do that, but.
Well, it even differs in the NCDR registries too, Carol. I mean, the PCI is the lowest, the ICD is the lowest, the chest pain's the average.
And average is average.
Yeah. So it differs in the NCDR in of itself. So it's pretty registry specific in general.
And that's interesting. So one thing we are doing, because that is one of the values that has the lowest audit point, and my guess is because the varying definitions between the registries. So for this audit, we'll instruct the audit company. We'll have a new audit company this year. We'll instruct the audit company that it can be a plus or minus 5 from the value that the site reports to what the value, what should have been recorded. We're giving the sites a plus or minus 5 wiggle room, if you will. So hopefully it'll be better audit this time, because it's so close on most of the audits where we have the discrepancy. It's kind of a weird thing. And I think it's good. We should take that back between STS and ACC and talk more about that. And I'll bring it up on one of our operations calls with our ACC counterparts. To IQVIA, when will issue showing missing for field VAD explant 2 be fixed? IQVIA?
Let me take that one. It's Melanie. Yep, that one is not listed. It's currently under review, but we are looking at doing another release at the end of this month. And that one is targeted to be included. I just pulled up the information. I think that was Jennifer that was asking. And also, I think there was a Susan that I had sent a message to. So Susan, if you're still on, that actually is the same issue of VAD explant number 2, which is STS 3945. So I'm following up with that support team member that you said you received an email response from. So the issue with VAD explant, again, is for the missing variable report, STS 3945. And we'll update the slide deck also, Carol, so we can include that as another one that's under review. And that's targeted for this month.
Thank you, Melanie.
You're welcome.
My predecessor captured data on paper. I was about to shred it all. What is the logic behind keeping the paper chart when everything is in the EMR? I mean, that's a good question. Some sites take notes. Some people who abstract on paper keep notes on paper. If they did follow up or whatever it may be, whatever they're using their paper charting for. So if you have anything like that, or you did any notes on your paper chart that you would refer back to something that is not in the EHR, then I would hold on to those papers, to the paper, but it's your choice. We don't require you to do that. Can you please answer all questions live? It's very hard to read the answers to some questions while listening to others. The information is important to all of us. So no, I can't talk and type at the same time. Sorry. Our company is participating in MIPS as a group under our ACO, so our surgeons did not sign for MIPS on individual basis. Is there any financial punishment for participating in MIPS at the level of individual provider? Victoria, not that I am aware of. If they're participating in MIPS through your hospital, then they wouldn't need to participate through STS. But I'm not the MIPS person for STS, so I would defer you to Donna McDonald, and Leanne can put her email in the chat box for you. She'll be able to answer every and all things about MIPS. Next question. For COVID-19 exclusion, is that for only the patients who tested positive prior to the procedure, or while still in the hospital? It's any patient who has tested yes. So any, I'll turn over the form here. So any yes that you, and I just thank you, Leanne, for typing in all those email addresses. This is the data collection form, and it's in the risk section where we have the MIPS fields. Any patient that you code 11, 12, 13, or 14 on any of these choices will be excluded from analysis right now, regardless of the date that they tested positive. We will look at it once we get this data back from in our PUF file from DCRI, which will go to our research center. We will look at this more closely at the surgeon leadership level, and look at the dates, look at all of these choices and see the impact. And we may start excluding cases related to date and when it occurred to compared to surgery. But that's in the future, and that's something senior leadership, surgeon leadership will decide at STS. So for right now, for Harvest 4 2020, we will be excluding Harvest 2 and 3 and Harvest 4. We will be excluding any yes from analysis. I had additional questions regarding post-op patients and COVID PCR testing. I do have an additional question. During the monthly calls, the conversation was had that unless you have that positive PCR, we cannot take yes or code 11. If I am to use the below FAQ, I would then be coding based on the patient self-reporting to us that they had a test and use code 11, yes, per surgeon leadership, that can be accepted. And that's correct. Melinda, do you want to speak on that? Because we did clarify that with the surgeons.
We did, and I actually communicated with Joy, I think just yesterday about this. So per the surgeon leadership, if the patient tells you, you're doing a follow-up call, I think that was the example in the FAQ. Can't remember exactly, but you're doing a follow-up call and the patient says, yes, I had a positive PCR test, then we can accept that. The patient has told you that they have had that, and the surgeon leadership agreed that that was acceptable to take.
Okay, thank you. And I see Joy just put her hand up, so I'm gonna unmute her, and then there was one before her. So Joy might have some clarification on this question, so I'm going to take her. And Joy, if you're there, you just have to unmute yourself.
Hi, how are you?
Oh, good, you worked. Good. How are you?
Hi. So yes, Melinda did get back to me and I hit enter too soon. So basically my question goes back to the first question I had asked about the patient who was readmitted and it was a rapid. And if we're not allowed to take the rapid, which is, documented and it's a physical test, why is it that we could take a patient self-reporting? Because to be honest with you, how do we know these patients know the difference between a PCR or a rapid antigen test?
Isn't a rapid test still a PCR test? An antigen test is a blood test, isn't it?
But if we only have the antigen,
The
you're saying,
antigen is a blood test, so it says that the patient.
because not all rapids, are all rapids PCR?
Well,
Yes, the surgeon leadership believes that all rapid tests are PCR tests.
yeah, I think the antibody test is an actual blood test, and I'm not sure that it's not. The antibody is blood test, and it is. I don't believe it's that rapid. I think most rapid tests that they're doing in the ER these days are the PCR testing.
Okay, thank you.
Okay, and thank you. Thanks, Melinda. And then let's see, I'm not sure your name, but I'm going to unmute you. Go ahead if you could unmute yourself.
Hi, it's Laura.
Oh, Laura.
So I'm wondering, so I had a patient who post-op, 38 days post-op, turns up COVID positive. I am assuming that I'm supposed to hit 10 for no because they are 38 days post-op and not 30 days post-op. Is that correct?
Yeah, that's correct. It's within 30 days of surgery for Harvest Code 14. Yes, after discharge within 30 days of surgery.
Okay, so there's nothing else I fill out, just put that 10 for no.
Carol, this is actually a good thing to bring up. When they have a test, a positive test like that, that's outside of one of those codes, would we still want to put the date, in the temporary date field, or I don't know, it's just food for thought.
Yeah, we should just collect the dates on those that are marked yes.
Okay.
Okay, so if I did put in the date, will it kick it out and realize that it was 38 days past? Because I contemplated that too. Looking at the FAQs, I thought, well, I can't say that he had COVID, but I thought you guys wanted to know who did. So I figured if I put the date, it would know that it was 38 days past.
And we can look at it on the back end that way. So all that DCRI is looking at when they pull out cases for analysis are these harvest codes 11, 12, 13, and 14. They're not looking at the date field, but our research center will look at the date field in relationship to the surgery date, and they'll be able to determine when that patient was coded. If you code this, we would just assume that it was a yes. However, some sites were coding the date of any testing. I think those sites have corrected their coding now. They were coding the date of any testing, not positive COVID-19 testing. I think there was just confusion at some sites. So we are looking at the yes field, and then we would look at the date field. If you have a no and a date here, it would probably get thrown out. And I don't know. We would have to talk to our research center about what they would do with those, but they haven't gotten the data yet to look and see what that number is of sites that have those coded patients like that.
So when you get that answer, and hopefully it's soon, can you put it in the book so that should I just take that date out? Because I don't want the case to get thrown out if I know it was 38 days post-op. So
yeah.
If I confuse someone, then I might as well just take the date out.
It would probably be better just to take the date out, but we're not looking at the date field to remove that case from analysis.
Oh, okay.
We're just looking at the yeses. The yes.
And it won't matter if the date's in there or not, because you're basing it all off of that temporary field 7230.
That's correct. Yes.
Okay.
Okay. Thank you.
Thank you.
Thanks. Okay. Let's see. Diane has a question. In the IQVIA non-analyzed report, are the COVID patients included? COVID positive patients included? Can they be excluded, or can there be a filter to allow us to exclude them? I realize they will be excluded from the analyzed report. IQVIA, did you want to take this one?
Sure, this is Jeanette. So currently the participant dashboard does include the COVID positive patients. We have been asked by STS to add some additional options to allow you to choose whether those patients are included or not. And we are looking at making that change in an upcoming release.
Great, thank you. Thanks, Jeanette. In previous harvest, the original deadlines was the 3rd, February, May, August, November, the 2021 dates of the second Friday. This could be difficult for managers in high volume programs. So just as a refresher, prior to, I think, 2017, we did harvest only 2 weeks. So you only had 2 weeks to harvest your data in. We've gone to continuous submission. So you have however long to clean up to get your data in. You have 6 weeks to clean it up from the 30-day follow-up window. Last week, we were supposed to have it the second week of each month. So that's the dates that we'll be sticking with. Again, this is a continuous harvest. So much different than what was previously available with the 2 weeks. And I can tell you just from looking at the rate of site submission, most sites still do only submit the 2 weeks prior to harvest close, unfortunately. So hopefully 6 weeks will be enough time for you to get your 30-day follow-up in. Next question, will the COVID exclusion apply if patient tests positive only during readmission? Will it also be excluded? So any of these yeses will be included. So yes, prior to hospitalization, yes, in hospital prior to surgery, yes, in hospital after surgery, or yes, after discharge within 30 days of surgery. Next question, has the Harvest 1 report been completed yet? So the Harvest 1 risk adjusted report is available on the IQVIA platform. The benchmarked report is in its final testing at IQVIA and should be available soon. Hopefully, very soon. Okay, my 3-year data submission resulted in many duplicates. For example, my cabbage mortality had 1 duplicate. My raw data reflects results based upon the wrong number of patients. How can I be confident that what is ultimately reported by DCRI is based on actual numbers and not the inflated numbers showing on the IQVIA dashboard. This has been an ongoing problem. I'm a little nervous about what the risk-adjusted numbers will show. So IQVIA, did you want to take this one? I'm not sure.
There's kind of a lot there. So the data that is analyzed by DCRI is exactly what is sent with them. With regard to mortality counting, they do consider mortalities based on the patient, not on just the surgical case. We are revisiting some of the mortality presentations in the participant dashboard in light of feedback such as this. So please do not be concerned about the the counts that are shown in the participant dashboard influencing the analysis, because the analyzed data set runs off of the submitted records. And so if you did have 2 surgical cases for the same patient that had a mortality, the analysis would consider that, and the double counting situation should not occur there. Hopefully that addresses your question.
Thank you, Jeanette. Questions are being typed by some members of the team to some questions while you are addressing others. Yeah, I think they're trying to answer questions that are specific to the user, that the user and user submitted in. Thanks for letting me know. If a patient tested positive in November and then tested negative before surgery in December, do we ignore the positive test in November? Melinda, I'm going to let you take this one because I know that we've answered something similar about positive, negative testing. And I don't want to.
From my understanding, from what we've discussed, that we want the positive test. So if the patient tested positive in November and then tested negative in December, we still want to capture that positive test, unless I'm under the wrong impression.
No, that's what I thought too. And I just didn't want to, because I know we had talked about it, and I think it had been brought up on a previous call. And I thought we put clarification in the training manual on it.
I think it is in there that we do want to collect the positive test. And like I saw further down in this chain of communication that even, because we do have that one, is it code 10, where it's prior to surgery. So any positive we would want. I don't think we have a date restriction on it, is what I'm getting at.
Right, I think you're right. Okay. Thank you. Regarding COVID tests, are positive saliva test results acceptable? But it has to be a PCR test. And I think we have pretty detailed instructions in the training manual. I thought I just had something pulled up, and I'm not sure where it went. Okay. So I think that this is, and I'm not going to read through this, but I think this will explain some of the differences. The rapid testing is PCR testing. It's not an antigen test. Antigen test is a blood test that checks for antigens in your blood. Oftentimes the labs, the blood banks will do these as they're collecting blood to check for antigens in your blood. So I'm not sure, but UC Davis has a nice website that will explain the difference in the different types of testing. Beth, when you say antigen testing is often referred to as a rapid test, I don't believe that is completely true. I believe a rapid test is a test that has fast turnaround results and could be a PCR test, not an antigen test. And And those rapid tests can be turned around in as little as 24 hours, but they are PCR testing.
Yeah, I think the key here is that we want the PCR testing. And, you know, there are lots of different types of testing out there, and they're probably still developing new types of testing. So the key here is the PCR. So when you're looking at your test results, that's what we're really looking for, that type of testing.
Thank you, Melinda. Why was rheumatic removed for mitral disease? It's listed for other valves. So it's here, rheumatic is here for mitral. It's considered a class 3A restricted leaflet mobility. So maybe you just missed it on there. Next question. If my site is not entering the TIN now, we should start entering that starting January 1st, 2021. Is that correct, or do we need to go back? We really, STS is highly recommending that you go back to January 1st, 2020 and enter those TINs. We're not going to make you do it, and it's not going to stop your data from going in, but if CMS decides that they're going to do something using TINs for surgeon reimbursement for a larger population outside of MIPS, you will have to go back and re-enter them. So we're just recommending that you do that now. Next question. In my institution, our lab labels nasal swabs as PCR nasal or rapid nasal. The rapids do not say PCR. Does that mean I can accept the rapid test since it is a nasal swab? I have not been coding the ones that say rapid, and I think it will say PCR positive. So I would check with your lab if that's a PCR test or not. It should be a PCR test that you need to code yes. I think a previous question was asked about the rapid antigen test done by saliva, not antibody test done by blood. Can we count rapid antigen test along with the PCR test? No, it has to be a PCR test, not an antigen test. Those options on the dashboard need to be able to exclude TAVR and TMVR's patients too. And I'm not sure that we've talked about that yet, but that could be something that we add on for one of our elaboration calls, the IQVIA team. And they are excluded from the PROC IDs that IQVIA is applying. Are those applied on, the PROC IDs are applied on the unadjusted dashboards, is that correct?
That's correct.
Yeah. So they are applied in the unadjusted dashboards already. Rapid tests are considered more accurate and okay. PCR testing is the hallmark testing, and according to UC Davis, rapid tests are considered PCR testing. So if you're using different terminology at your facility, then I would check to make sure that those are PCR tests. How do we code 7016 substance use and counseling if the patient was negative for drugs, alcohol, and tobacco? The patient was screened and answered no. Do we enter no for 7016?
No, you answered yes, because you screened the patient. They were not positive and they did not require counseling. So you would say yes, you fulfilled that screening, and counseling is only if needed. And in this situation, you didn't need counseling. So you would say yes, you fulfilled that measure.
Thank you, Melinda.
You're welcome.
Oh, and we're at time. I'm going to take one more for Darlene. She says, how many cases have to be submitted for the surgery to have data star rating report? So this information is provided in the national report overview that's in the IQVIA library or IQVIA resource section. You'll see it in there. It will provide you with the mortality thresholds for the mortality fields, and it'll provide you with the required number of cases, which is you'll see a section, it'll start with 10 cases for the cabbage, and then it'll list the mortality thresholds, and then it'll go into the valve sections. So I refer you to that. Make sure if you have questions, you reach out. It's a very detailed report, but it'll provide you everything you need regarding how cases, what's what allows cases to be included in analysis and how the analysis is performed. Okay, just one more for Lucretia. Can you repeat the comments about COVID negative and capturing the data? Only put the date if positive. Yes, only put the date if the patient has a positive PCR test. Okay, anything to add, Melinda? IQVIA, are we good? Okay.
Oh, Carol, let me just a quick announcement. This was one of the items in the that I responded to in chat. The updated version of the errors and warning checks have been updated on the library. So you can go ahead and take a look if you wanted an updated version of that for the actual logic checks. So just wanted to make that announcement.
Great, thank you. And okay, thanks everybody. I hope you have happy holidays and a peaceful new year, and we will talk again in 2021. And so happy that 2020 is ending. 2021 is going to be a better year for all of us. So I hope everyone takes care, stays safe, and we'll talk soon. Thank you.